Chapter 21 in the Jarvis focuses on the assessment of the abdomen. To get the most from your text, make sure you're doing your out loud subjective assessment, practicing your objective assessment, and really thinking about the RN level analysis, interpretation, prioritization, and plan of care. The focus of the abdominal unit really is to understand the external and internal anatomy and physiology and how your exam then relates to those internal structures. We're focusing on inspection of the GI tract and abdomen, auscultation of both the abdominal structures and the vascular structures, percussing for air, organs, and fluid, and light and deep palpation. For external surface, you should be familiar with both the 4-quadrant nomenclature as well as epigastric, umbilical, hypogastric, and then if you'd like, you can also use the hypochondriac, lumbar, and iliac terms as well. You should know which structures on which organs are in which of the 4 quadrants, and that's essential. So you should be able to recite those. You should know if somebody has pain in one of those quadrants, what your differential diagnosis is. And you should know if an organ is enlarged, where it will be located once it is enlarged. If you lift off the skin and musculature of the abdominal wall, this is kind of what the internal anatomy looks like. One of the things that's super important to remember is that the liver and the spleen are located up underneath the rib structure, and it's really difficult to palpate the liver unless it's enlarged, but the spleen is never palpable unless it's enlarged. The large intestine starts in the right lower quadrant with the cecum, where it moves from small intestine to large intestine, and then turns in the right upper quadrant at the hepatic flexure, where it basically is a bend at the liver, and then goes over to the left upper quadrant where it turns at the splenic flexure, which is a bend at the spleen, and then goes down where it turns from large intestine into kind of sigmoid colon in the left lower quadrant, and then into rectum and anus. When you are listening and then palpating, essentially what you're auscultating and then palpating in those 4 quadrants primarily is large intestine, and then any other organs in that area that might be enlarged, inflamed, or diseased. If you were to lift off then the small and large intestine and look deeper inside, so we've also taken off the stomach, the spleen, and the liver and gallbladder. You can see the kidneys, you can see the duodenum where it is attached to the pancreas, so the stomach has come off, and then where it turns into the small intestine and feeds down. And you can see how the pancreas is kind of a midline leaking over into the left upper quadrant. And you can see the vasculature here as well as the ureters coming down from the kidneys. You can see the adrenal glands, the bladder itself, the ovaries on a female, and the bony structures underneath. When you are assessing a bariatric or morbidly obese client, I just want you to really appreciate the fact that the internal organs, even though there's a larger layer of visceral or internal fat as well as the external fat, the internal organs are still between the rib cage and the pelvis, and you still need to do your assessment similarly to you would do on a normal sized patient. So don't palpate the lateral fat. You might have to adjust a little bit for the pannus and kind of move things around a little bit. But the abdominal assessment and auscultation should not be very lateral. It should still be focused around the umbilicus and between the pelvis and the ribs, kind of keeping that as your box that you're assessing the abdominal structures in. You're going to collect your subjective data about the patient in terms of abdominal and GI tract. So you're going to ask about their appetite, any difficulty eating or swallowing. Do they have any food intolerances? Have they been experiencing any abdominal pain? Ask them about nausea or vomiting and when it occurs, or if it's with any specific foods. Ask them about bowel habits, and again, if it seems to be related to any specific foods. Past abdominal history, including diagnoses and surgeries, and then any medications that they take. And then do a nutritional assessment. And I think not only is it helpful to ask patients, like, what do you eat on a normal day, but ask, like, what did you eat yesterday, and have them tell you a full day, because a lot of times people tend to idealize their diet. If you ask what do you eat on a normal day, they'll tell you what they would ideally like to eat, but they may not tell you what they've been eating lately. So if I asked a nursing student, for example, what do you eat on a normal day, they may tell me, what they would assume is an ideal nutritional diet. But then if I ask, what did you eat yesterday, I'm going to get a more truthful, like, hey, I'm really stressed out and short on time type of diet. As far as our objective history goes, we are going to change up the order a little bit. We're going to do inspection first, and then auscultation, then percussion and palpation. And the reason that you need to auscultate before you percuss or palpate is because palpation will increase bowel sounds, and you will get falsely normal or hyperactive bowel sounds on the patient. So when we inspect, we're looking at things like contour, symmetry. We look at the umbilicus to see if it's, an innie or an outie, but to see if there's any protrusion like a hernia. You want to look at the skin to see if there's any striae or scars. Look for pulsations or movements that would suggest an underlying aneurysm or vascular problem. Note any hair distribution, and then the demeanor. And by demeanor, you're thinking about the overall tension of the abdominal muscle wall. So does the person appear to be guarding? Are they tense or are they relaxed? In terms of documenting contour, these are your options. You can describe the abdomen as flat, round, protuberant, scaphoid. You'll also note that people will describe the abdomen as obese or with a large pannus. And that would be, past protuberant. And if you're describing a pregnant abdomen, the correct term would be gravid. Some abnormal findings on inspection would be an obvious hernia or a diastasis recti. Hernias then can be classified as reducible, which means that when the patient is lying down and the abdominal wall is relaxed, you can push the hernia back through the abdominal wall with some pressure. And you can herniate fat, like mesentery. You can herniate muscle, or you can actually herniate gut. So you can actually have a bowel that has herniated. You can also have an incarcerated hernia, which is part of the abdominal wall or bowel that has poked through that you can't push back through. But there's still good blood flow. And if it's bowel, usually it's not fully obstructed. With a strangulated hernia, this is a surgical emergency. And if you ever note this, would be a time where you should report it to the physician immediately. So a strangulated hernia is stuck. So if you think about incarcerated as being kind of like in jail but still alive, but strangulated being like actually being strangled and there's no blood flow and they're going to die. So they usually have severe pain. Oftentimes it turns purple or blue because the tissue is getting cyanotic. If it persists, it turns black and it can even become necrotic and gangrenous. And that truly, again, is a surgical emergency. So somebody who presents with a discolored, very painful hernia, you would call the physician, start a large gauge, IV, draw bloods, prep them for surgery, treat them for pain. A diastasis recti is where you have a separation of the rectus abdominis muscles, and those are the ones that run from like the xiphoid process to the umbilicus. So it's kind of the up and down abdominal wall muscles, and they're normally attached by fascia in the middle. And throughout like pregnancy or obesity or surgery, sometimes the fascia gets separated and the two halves kind of pull off to the side laterally, and then when the person goes to sit up, the sides separate and there's a large bulge which looks very similar to like a ventral hernia down the middle. So it's a large bulge in the midline. This is also common in babies. So it's a normal finding in babies that resolves, and it's an abnormal finding in adults, especially women after pregnancy. I'm sorry, my bulldog is making all sorts of weird noises. All right, bowel sounds. So we always auscultate bowel sounds in all four quadrants. A couple of places that are super important to listen to is at the ileocecal junction, which is in the right lower quadrant. And then oftentimes I also listen over the epigastrum. So you want to listen to bowel sounds and vascular sounds prior to percussion and palpation so that you don't mess up the sounds. And you want to use a diaphragm and light pressure because normal bowel sounds are high pitched. And the diaphragm is used for higher pitched sounds. So start in the right lower quadrant and move clockwise. Technically, you listen for a full minute in each quadrant. Between 5 and 30 sounds per minute is normal. Fewer than 5 sounds a minute is hypoactive, and more than 30 sounds per minute is hyperactive. And so you go right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant, kind of following the large intestine from start to finish. The reason you do this is because if there's an obstruction, you will hear just before the obstruction really loud, high-pitched tinkling noises, which is air hitting up against the obstruction, and that's referred to as borborygmi. If you are going to document bowel sounds as being absent, you have to have listened for at least 4 minutes, so 1 full minute in every single quadrant to say that there are sounds, the bowel sounds are absent. And then you can go back and listen to vascular sounds using the bell. So vascular sounds are basically the aorta and then the renal arteries, and then where the aorta splits off into the iliac arteries and over the femoral arteries. And you want to listen with the bell because you'll hear bruits. So you want to use slightly firmer pressure to try to hear a little bit deeper. So listen over the aorta itself, up where you see just below the xiphoid process, and then again just above the umbilicus, and then kind of off to the side halfway in between those to listen to the renal arteries. Just below the umbilicus on each side you can listen to the iliac arteries, and then where you feel for femoral pulses you can auscultate the femoral arteries. So a normal finding would be no sound at all. But patients who have hypertension, especially chronic hypertension, are more likely to have bruits. You want to percuss the abdomen. Again, this is not something that's done normally unless you're concerned about fluid or free air in the abdomen, or unless you're doing some sort of a higher level exam. So we don't normally percuss during a routine physical. Percussion around the umbilicus should give you a tympanic sound, which is normal because there's only bowel around the umbilicus. And then over the solid organs like the spleen, liver, kidneys, and if the bladder is full, you'll hear a dull sound. Or if you percuss the ribs, you'll hear a dull sound. And then if there's fluid, if the person is supine, you'll hear fluid in the flanks, or if they're on their side, you'll hear, fluid at the level of the fluid itself. If the person has gastric distension, you'll probably hear a hyperresonant sound, so just a much louder, high-pitched sound. And when the person is sitting forward and you're listening to their back, you want to palpate over the CV angle to check for pain in the kidneys. So this is just an example of where you could percuss. This is giving you kind of over the, again, the cecum and the large intestine. 6 and 7 are more over the liver, so those should be dull. 8 and 9 kind of over the stomach. And so depending on how much gas or air is in there, those might be a little hyperresonant. But all of these are kind of over the intestines, so most of them should have a tympanic sound. And again, when you have the person seated and have them lean forward, you can percuss. And you should do indirect percussion, usually over the kidneys themselves. So place one hand on the back at the level of the 12th rib, so where it comes off of the 12th thoracic vertebrae, and then kind of bump your hand with the ulnar surface of your other fist. And the person usually will feel kind of like a thud. And if they're there for back pain, it might be slightly uncomfortable. But if they're there for a kidney stone or any sort of kidney infection, you're going to have to peel them off the ceiling after you do this. At times you might be caring for somebody who has acidic fluid in the abdomen, such as a patient who has cirrhosis or tumors from cancer. So there's 2 tests that you can do. The top picture here is the shifting dullness test, where you have the person kind of semi-Fowlers, and you percuss from top to bottom, hearing tympany and then dullness, and the transition point is the fluid level. And then you roll them onto their side and you percuss again top to bottom, and again you hear tympany where there's air, and then dullness where there's fluid. And this gives you an idea of how much fluid they have in their abdominal cavity. The other test is called the fluid wave test, and you either have the patient or an assistant place their hand in the middle of the abdomen, directly over the umbilicus and like towards the xiphoid process, and then you place your hand on one side of the abdomen, so like one flank, and on the other side, the other flank, you give it a good tap. And if you can feel a wave hit your other hand, then it's positive for having at least a liter of fluid in the abdomen. So that's called the fluid wave test. Obviously, we have ultrasound and CAT scan and things like that readily available to us, but this is just a good quick test that you can do at the bedside to get an estimate as to how much fluid there is in the abdomen. When you're palpating, you're going to start with light palpation, and you want to follow the same progression as you did with auscultation of the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant, unless there's pain. And if there's pain, then you want to palpate that area last so it doesn't skew the rest of your assessment. Remember, again, that the liver and the spleen are under the ribs, so they're not palpable unless they're enlarged. And then the liver would be palpable in the right upper quadrant, and the spleen would be palpable in the left upper quadrant. If the patient has severe COPD with severe barrel chest and hyperinflated lungs chronically, that causes the diaphragm to be extended downward chronically and may actually displace the liver downward. And so you may be able to palpate the lower edge of the liver always in a patient with severe end stage like emphysema. So now you would go back through and do a kind of a deeper palpation after light palpation. So light palpation, we're kind of just like searching for any abnormalities on the surface. Deep palpation, we're searching more for like organ pain. And you're only going about 2 inches deep. We're not trying to hit their spine from the top. But it is, like, moderately deep palpation. Going back again, right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. And if you have a patient that has like a really like large abdomen, you can use a bimanual technique. And when you're palpating the kidneys, we use a bimanual technique to actually cup and get in and palpate the kidneys. Avoid deep palpation if the patient has a rigid abdomen or pulsating masses, or if you know that the person has like a Wilms tumor or something like that that should not be palpated. If you do identify a mass while palpating the abdomen, you should document the location, so which quadrant it's in, the size, the shape, the consistency. If you can tell if the surface is smooth or nodular, is it mobile? So like when you push on it, can you move it, or does it feel fixed to the tissues, or does it move up and down with respirations? Is it pulsatile, and is it tender to the patient? Keeping in mind that tenderness, even though it's a subjective finding, is very critical in the differentiation between like a lymph node that's inflamed from illness versus a lymph node that's inflamed from disease like cancer. So what can you normally palpate during your assessment? Well, the xiphoid process in the ribs, a little bit of that liver edge underneath the right kind of costal margin. And if you're really palpating deeply, maybe the lower pole of the right kidney. If the aorta, if the person is thin enough, you might be able to palpate the aorta or feel the pulsatile movement of the aorta. And then the rectus muscles, the cecum, which is the beginning of the ascending colon, and then the end of the descending and sigmoid colon on the left-hand side. A full bladder in an adult, you might be able to palpate just over the pubic symphysis, as well as a gravid uterus. So past 12 weeks, you might be able to palpate the top of the fundus in the uterus. And in somebody who's like super thin, you may even be able to palpate the sacrum. So you might be able to push hard enough to feel their spine on the other side. Some additional tests that we do. So if we're concerned that somebody has right upper quadrant pain that radiates through to their back, just underneath their scapula on the same side, it gets worse after eating, it's sharp, maybe radiates up into the chest. A lot of times people come in with this chest pain, but when you have them point to it, it's more like epigastric, almost right upper quadrant pain. You can do a test which is called the Murphy's sign or Murphy's test to see if they have what's called inspiratory arrest. So you put the person in the position of comfort, which is usually semi-Fowler's. Have them take just a couple deep breaths in and out and relax the abdomen as much as they can. You're going to place your fingertips with the tips pointing towards the ribs in the right upper quadrant. Have them inhale, exhale, push your hands down and try to get like almost up underneath the ribs on the right side. and then have them inhale in. And when they take a deep inspiration in, they should have severe pain right there in the right upper quadrant, and that would be a positive Murphy sign. And they call it an inspiratory arrest because the person actually catches their breath and they can't take a full breath in because it hurts so bad, and then they stop. And that's like a good diagnostic finding. We still will rule out cardiac, so we'll still do an EKG and a troponin and all of our cardiac testing, but we also will add on like a lipase to make sure that it's not a gallbladder or pancreatitis. So Murphy sign is indicative of gallbladder, gallstones, and again, that's an inspiratory arrest with pain in the right upper quadrant. Some tests you can do for the right lower quadrant are rebound tenderness, where you push in, it kind of hurts, you let go, it hurts worse. That's also called Blumberg's sign. The psoas test or ellipsoas test, iliopsoas muscle test. I don't know why that one's so hard to say, but you have the person, you raise their right leg and then have them try to hold it while you push down on it. Engaging the psoas muscle, which runs basically from the top of the anterior thigh inside the pelvis and attaches up on the inside of the anterior spine. When that muscle engages, the appendix is right up against it. So if the appendix is inflamed, it's incredibly painful. So engaging the psoas will cause increased pain. And then there's the obturator test, which is basically very similar with a rotation of the right extremity. All of that is just moving the psoas muscle, which is kind of irritating or aggravating the appendix. So if any of those are positive, it increases our suspicion for appendicitis. And then in your book, there's the Alvarado score, which is the Montreal score also, which evaluates right lower quadrant pain and lets us know how likely it is that the person has appendicitis. So some developmental competence, infants and children. In little kids, the liver is larger and more easily palpable just because it proportionally takes up a larger amount of the abdominal cavity. As you grow, then it kind of moves up underneath the ribs. It's less palpable. The abdominal wall muscles are thinner in little kids, so it's easier to palpate organs, so you don't have to push as hard. During pregnancy, there's just a lot of GI changes, things like nausea, vomiting from morning sickness, a lot of reflux, decreased GI motility, constipation, hemorrhoids from increased intra-abdominal pressure, decreased bowel sounds, skin color changes. So just think about when you're doing your assessment, what's normal for the pregnancy based versus what might be abnormal based on disease. And then with aging, patients have decreased salivation, delayed GI emptying, and decreased liver function, as well as a decrease in gastric acid, which increases the risk of pernicious anemia. In addition to that, they have oftentimes chronic constipation, but which is usually used due to other causes like decreased fiber intake, decreased water intake, decreased ambulation, a side effect of medications, things like that.